Okay, let's jump in. Welcome to the Deep Dive. Today, we are immersing ourselves in some of the highest stakes educational content out there. We're talking about the crucial protocols,
Sure.
the razor-sharp clinical standards you need in an emergency room.
hmm
This is knowledge that, literally translates into life or death decisions,
Mm.
all made under incredible pressure.
That's absolutely right. Our mission today is to give you a really structured, comprehensive summary of these emergency medical standards.
This isn't just a list, right?
No, not at all. We're providing the rationale, the clinical alerts, all the nuanced details.
Yeah.
And it's all derived from specific medical literature dated 21-5207.
So it's for medical students, young professionals,
Yeah.
really anyone who needs this high-yield knowledge integrated and fast.
Exactly. We're zeroing in on rapid assessment, immediate intervention protocols, and what are really non-negotiable patient safety points.
So we have to start where every emergency system begins, immediate life support. Specifically, let's talk about cardiac arrest actions. So you find a patient in arrest. The first move is so simple, but I think it gets overlooked sometimes. You have to get them laid flat on a hard surface.
It sounds basic, but it's all about optimizing the efficacy of your chest compressions. You lose so much force on a soft bed.
And that leads to a really interesting and I'd say highly nuanced tool, the precordial thump.
Ah, yes. The source material is very restrictive on this. Very.
So when can you actually use it?
You only use it within the first few seconds of a witnessed or monitored arrest, and only if the monitor shows pulseless VT ventricular tachycardia or VF,
And there's one more condition, isn't there?
the big one. You only do this if a defibrillator is not immediately available. I want to be clear, it's not a standard part of routine CPR. It's a very specific, rare intervention.
That distinction witnessed arrest, right, rhythm, no defib, is what separates protocol from just, impulse.
Hmm.
So assuming the patient's airway isn't secured, you move straight into assisted ventilation with compressions.
You do. You deliver 2 effective rescue breaths, but the timing here is absolutely critical.
How so?
Both breaths have to be completed within 5 seconds total. Then you're immediately back on the chest. You have to minimize that hands-off time.
Okay, but then everything changes once you get a secured airway.
Oh, completely. Once a skilled practitioner gets the endotracheal tube in, it's a different algorithm.
Because you're protecting against aspiration, keeping the airway patent.
And crucially, you no longer have to stop compressions to ventilate.
So that's the sustained CPR strategy. What does that look like?
You continue cardiac compressions uninterrupted at a rate of at least 100 per minute. Continuous blood flow becomes the absolute priority.
And the breathing.
The ventilation becomes asynchronous. You ventilate the lungs at a controlled rate of 10 breaths per minute, totally independent of the compressions.
Okay, now the sources really emphasize a warning here.
They do, a critical one.
Yeah.
You have to take extreme care not to hyperventilate the patient.
Because more isn't better.
More is definitely not better here. Excessive ventilation raises the pressure inside the chest, which it sounds counterintuitive, but it actually decreases venous return to the heart.
So you're undermining your own chest compressions.
You're completely counteracting the benefit. It's a fantastic example of a protocol that's designed to optimize 2 competing needs, flow and oxygenation, without one sabotaging the other.
And for giving drugs during all this, what's the preferred route?
Central line. You need that rapid access. So we're talking about inserting it into a large vein like the jugular or the subclavian.
Which brings its own risks.
Huge risks. It means faster drug delivery to the heart, sure, but the procedure itself? You can puncture an artery, cause a hemothorax, a pneumothorax.
Any of which could just end the resuscitation attempt right there.
Exactly. It highlights why it has to be reserved for skilled hands.
Let's shift focus. From the mechanics of resuscitation to the causes of collapse. The 4 categories of shock. And this starts with a vital diagnostic lesson for everyone. A normal blood pressure does not rule out shock.
This is so key, especially in young, healthy people with great compensatory mechanisms. We think of shock as SBP less than 90, right?
That's the classic definition.
But that's often a late sign. The sources note that in a healthy adult, by the time you see a consistent fall in systolic blood pressure, they may have already lost 30% or more of their blood volume.
Wow. Their body's just masking the severity until it all falls apart.
It is. So let's break them down. Category 1 is the most common. Hypovolemic shock. Not enough volume in the pipes.
Usually bleeding.
Often hemorrhage, yeah. External or internal from things like a fractured pelvis or a liver or spleen injury.
But it's not just blood loss.
No, don't forget the non-hemorrhagic causes.
Yep.
Severe vomiting, burns, or that classic third spacing you see in pancreatitis, where fluid just leaks out into unusable spaces.
Okay, category 2.
Cardiogenic shock. This is a pump problem. The heart just isn't working effectively.
Like in a big heart attack, an ACS, or maybe myocarditis.
Exactly. Decreased contractility. Or it could be a critical arrhythmia like an SVT, VT, or a high-grade heart block that's preventing the heart from filling or ejecting properly.
Then we have category 3, distributive shock.
Where the pipes are too wide, the circulation dilates so much that the volume you have can't fill the system.
Sepsis is the classic example.
Sepsis, anaphylaxis, neurogenic shock after a spinal cord injury, or adrenal insufficiency. And clinically, these patients might actually feel warm at first, which is a big clue.
Unlike the cold, clammy patients from the first 2 categories.
Right. And finally, category 4, obstructive shock. Something is physically blocking blood flow.
The big 3 here are PE,
Pulmonary embolism, yes. Blocking flow out of the right heart,
cardiac tamponade,
preventing the heart from filling,
and tension pneumothorax.
compressing the heart and the great vessels. A true medical emergency.
Let's stick with that one. Tension pneumothorax, it demands immediate recognition. How does it happen?
It often follows procedures like attempts at central venous cannulation or using positive pressure ventilation on a patient with a fragile lung.
And the diagnosis is purely clinical.
Purely. You look for that key clinical triad. Increasing breathlessness and cyanosis, tachycardia with a falling blood pressure, and decreased chest expansion or breath sounds on one side.
And what's the one really unique physical sign?
The tracheal deviation. The trachea gets pushed towards the other side, away from the tension, and the neck veins are usually bulging because blood can't get back to the heart.
If you see that picture, you don't wait for an x-ray.
No, you decompress immediately with a needle.
Okay, let's switch gears to another immediate threat, managing anaphylaxis. The core principle here is epinephrine.
Always. The epinephrine principle. Your initial steps are high-dose oxygen, get the patient lying flat, maybe elevate their legs if they're hypotensive, and stop whatever is causing it.
And the first-line drug, the absolute non-negotiable,
Is adrenaline, epinephrine, specifically the 1 in 1,000 strength given intramuscularly, right into the thigh.
the dose being 0.3 to 0.5 milligrams.
Correct. And giving it IM is key because it ensures rapid absorption. It's often much faster than trying to get an IV line in a patient who's crashing.
Only after they're stable do you move on to second-line measures.
Only after cardiorespiratory stability is achieved. Then you can give H1 antagonists like cetirizine, H2s like ranitidine, and 5-E-hydrocortisone. They help with the inflammation, but they're purely supportive. Epi saves the life.
And there's a huge clinical alert in the source about what to do after you've given adrenaline.
A major one. Any patient who receives adrenaline must be admitted for at least 6 to 8 hours of observation
Boy, that.
because of the risk of biphasic anaphylaxis, a late, unexpected deterioration that can happen in up to 5% of cases, even after they seem to be getting better.
Missing that observation period would be a massive risk management failure.
Absolutely.
Let's move from medical to trauma. Severe head injury. The goal here is all about perfusion.
It's all about preventing that secondary brain injury. And the fastest way to cause secondary injury is to let the patient get hypotensive.
So initial management is aggressive IV fluids crystalloids to maintain a normal blood pressure.
And you're aiming for a very specific target, a mean arterial pressure, or MAP, of greater than 90 millimeters of mercury.
That's the minimum you need to ensure adequate blood flow to a potentially swollen brain.
Exactly. It's about maintaining cerebral perfusion pressure.
And with head trauma, we always have to be vigilant for that classic neurosurgical emergency,
The extradural hemorrhage.
which can happen after even minor trauma.
Trivial trauma, even. It's usually arterial bleeding. You have to watch for those classic signs.
Yeah.
A rapid deterioration in consciousness, that specific breathing pattern called Cheyne-Stokes, and the really ominous sign of a unilateral fixed dilated pupil.
And if you suspect that,
Urgent head CT and an immediate call to neurosurgery. Time is brain.
okay, shifting back to medical diagnostics, the most common presentation that demands immediate sorting, acute chest pain. The priority is always,
Excluding the killers.
which are
The big 3 you absolutely cannot miss are acute coronary syndrome, or ACS, pulmonary embolus, or PE, and aortic dissection.
we often look for atypical features, pain that's pleuritic or positional, or you can reproduce it by poking on the chest.
And while those things are less characteristic of ACS, the source material is explicit. You cannot exclude ACS based on those features alone. You have to assume the worst until it's proven otherwise.
For a confirmed STEMI, a major heart attack, thrombolysis is an option.
Yes, the clot-busting drugs, generally indicated within 12 hours of pain onset, but ideally within 6.
But you have to know the absolute contraindications inside and out.
You do, because the risk of catastrophic bleeding can outweigh the benefit. This is mandatory knowledge.
So what are they?
Any history of any kind of intracerebral hemorrhage, ever, a thrombotic stroke in the last 3 months, a known bleeding disorder, or significant head or facial trauma in the last 3 months. Those are the big ones.
That need for risk assessment is a perfect lead-in to pulmonary embolism diagnostics. It's a very stepwise process.
It has to be. It starts with calculating the clinical pretest probability. Basically, how likely is a PE based on the patient's story?
And that determines your next move.
It's the steering wheel. If the probability is low, you can use the PERC criteria to try and rule it out clinically. You only request a D-dimer blood test if that pretest probability is low and 1 or more PERC criteria are positive.
Which prevents a lot of unnecessary testing.
A huge amount. Because the D-dimer is sensitive, but it's not specific at all.
When you do need imaging, the standard is a CTPA.
CT pulmonary angiography, yes. But the VQ scan still has a very important role.
For which patients?
It's preferred if the patient is allergic to contrast dye or has significant renal failure. And it's also often chosen for younger patients, especially females under 40 with a normal chest X-ray, to reduce that lifetime radiation exposure.
Let's turn to the confused patient. Delirium.
The source defines this as a transient global disorder of cognition. It's a syndrome, not a diagnosis in itself. You're looking for fluctuation, disorientation, impaired memory, and difficulty paying attention.
So the job is to find the cause.
The immediate job is the causes review. We categorize them so nothing gets missed. So you think hypoxia, maybe from a PE or COPD, intracranial like meningitis or a stroke.
Metabolic.
Right. Renal or liver failure, electrolyte problems like hyponatremia, DKA. Then you have endocrine causes like thyrotoxicosis or Addison's. And finally, sepsis. Always think infection.
Is there a quick assessment tool?
The Mini Mental State Exam, the MMSE, is a good screen. A score below 24 really suggests an organic physical cause for the confusion and demands you investigate immediately.
Okay, let's spend some good time on a big one. Diabetic ketoacidosis, DKA management.
This one is so protocol-driven. It's less about a single quick fix and more about managing a controlled descent from a very dangerous metabolic state.
And like all critical care, it starts with
High-dose oxygen. And fluids. Aggressive fluid replacement is the absolute backbone of DKA treatment.
How aggressive are we talking?
1 liter of normal saline in the first hour, then another 500 milliliters per hour for the next 4 hours.
And the overall goal?
The goal is to replace their total fluid deficit, which can be 6, 7, 8 liters, gradually over the first 24 hours. The initial push is for resuscitation, but then you slow down to minimize the risk of cerebral edema.
Which is a life-threatening complication.
It is. Then, once you're resuscitating with fluids, you start the insulin.
A short-acting soluble insulin infusion.
At a rate of 0.1 units per kilogram per hour. And this is where the really complex balancing act begins. The potassium alert.
Okay, what happens to potassium?
It's going to fall precipitously. The insulin drives potassium into the cells, and the fluids dilute it. This can cause lethal cardiac arrhythmias.
So you have to replace it before it even drops.
You have to anticipate it. You start replacing potassium at 10 to 20 millimoles per hour, aiming to keep the serum levels strictly between 4 and 5. That is the magic window for cardiac stability.
Then there's the sugar paradox. The glucose starts to fall, but you're not done.
Exactly. Once the blood sugar hits about 15 millimoles per liter, you have to add a 10% dextrose infusion.
To prevent hypoglycemia.
Yes, but, and this is vital, you continue the insulin infusion and the saline until the ketones have cleared from the blood. The goal is to stop the ketosis, not just to lower the glucose.
It's such an intricate process.
It really is. And beyond these clinical details, success in the ED relies on systems, like triage systems.
The ATS or the UKNTS scales.
Right. They standardize patient risk. They dictate the maximum time a patient can safely wait to be seen by a doctor.
It's a critical safety net. For example, an ATS code 2 is an emergency.
And that means that patient must be assessed by a clinician within 10 minutes. It structures the chaos.
And what about professional responsibility? Documentation.
It's non-negotiable. You record all positive findings, and just as importantly, the relevant negative findings, the things you looked for and ruled out.
Avoid unapproved abbreviations.
Please, and when you're charting doses, name the digits. Write 4 milligrams, not just 4 milligrams to prevent reading errors.
The consultation record also seems like a huge safety mechanism.
Probably the most important one for a junior doctor. If you discuss a case with a senior, you document their name, their grade, the exact time, and the precise advice they gave you. It's an audit trail. It protects everyone.
And finally, the discharge letter.
It's a necessity. You have to write one if any tests were done, even if they were normal, if a new diagnosis was made, if meds were changed, or if the patient is referred for follow-up. It's all about continuity of care.
We have covered an immense amount of ground today. From the mechanics of CPR with a secured airway to the 4 shock categories and the really interdependent steps in managing DKA. The speed and accuracy required here is it's humbling.
It is, and the continuous insight, I think, is the link between physiology and protocol. Whether you're keeping a MAP above 90 in a head injury or replacing potassium in DKA, the goal is always rapid stabilization and preventing that secondary harm. Your knowledge has to be structured so you can deploy it instantly.
To help you all integrate this, here is a review exercise based directly on what we've analyzed today. A patient presents with signs of severe trauma, including blunt abdominal injury, and they are hypotensive. Describe the 3 critical pieces of blood work, besides a cross-match that should be sent immediately, and explain why a normal systolic blood pressure might be misleading in this context.